Hello everyone, welcome back to my channel. Today we are going to discuss a pediatric emergency, that is management of acute exacerbation of asthma. So as you know students, this is a frequently asked long question for both UGs and PGs. So listen to me very carefully and watch the video till the end so that you can write well in the exam, right? So let's get started. Whenever a child is presenting to you with acute exacerbation of asthma, what you need to do is you have to first go for a risk assessment, right? So if you're writing this way in the exam, that will fetch you a good marks, okay? So in risk assessment, what you need to do is you need to take a focused history, okay? And you need to do a quick clinical assessment of the child, right? So this is very important. Even the child is having an acute exacerbation, you need to do these two things at the beginning, right? So, in history, what you need to ask is you need to know the frequency of daytime and nighttime symptoms, okay? And you need to know the potential triggers of the child. You need to know what the child is currently on, which medicines, okay? These are the things you need to know, okay, from the parents. And you need to do a rapid clinical assessment, like you need to check the respiratory rate, you need to know all the vitals of the child, okay? You need to see whether the accessory muscles of respiration is working now or not, okay? And you need to do pulse oximetry, this is also very important. So after having done this thing, you need to do the treatment, right? And in treatment, the first thing is, as you know, in any emergency you should do the ABC. So what is that? Airway, breathing and circulation, yes. And first thing is you need to administer moist oxygen. Why? To reduce hypoxia, okay? And the target is to maintain the SpO2 above more than equal to 92%, okay? This is the thing you need to remember, it should be maintained above 92% at least, okay? And this moist oxygen you can give through either nasal prong or cannula or oxygen mask, right? So after giving oxygen, the next thing is you have to give inhaled bronchodilator, okay? And what is that? Salbutamol. What is salbutamol? This is a SABA. What is that? Short acting beta 2 agonist, right? And the other one is levosalbutamol, okay? So salbutamol is given, these are the two drugs which you should give, and this can be given either as a nebulizer, okay, or MDI, that is metered dose inhaler, okay. If you are giving in nebulization, the dose is 0.15 milligram per kg per dose, okay. And this thing you need to repeat at least thrice, okay, 20 minutes apart, right? And if you were giving MDI, right, like if the child was already on therapy, bronchodilator therapy in home, so they may take MDI puffs and come to you in hospital. So that is in acute exacerbation, they should take a minimum of 2 to 8 puffs at a time, right? So this thing you have to remember, okay? And what is the dose of levosalbutamol? This is just the half of salbutamol, and that is 0.075 milligram per kg. Okay, so whatever you are giving, it should be at least three times 20 minutes apart. This thing you should remember, okay? And along with this SABA, what you need to do is you need to continue the oxygen therapy. Why? Otherwise you will land up in VQ mismatch, okay? That is ventilation perfusion mismatch. So along with SABA, if the child is getting nebulization, then you have to add oxygen to it. Okay, so this is the thing you need to remember. This is the first line of management you need to do: oxygen and inhaled bronchodilator. Clear? That is salbutamol or levosalbutamol. Both are equally efficacious, students. But one thing you just need to remember: the side effects of this drug. So that is, there will be palpitation, tachycardia, tremor, anxiety. So these are the side effects, but you cannot see the side effect that time. You have to give the drugs, right? So the next thing you need to give is systemic corticosteroids, okay, and that is prednisolone. So if the child is being able to take orally, you need to give prednisolone at the dose of 1 to 2 milligram per kg per day in divided doses, okay. And if the child is not being able to take orally, that time you may give IV hydrocortisone, okay, or dexamethasone, right? So after corticosteroids, there is something called anticholinergic drug. And what is that in bronchial asthma? Yes, that is ipratropium bromide, and that is given in the form of, again, nebulization or MDI also, zero point 0.5. Clear? Next, so 4 drugs done, still the child is not responding, then you can give adrenaline, okay, and this can be given in two routes: either you give IM or you give subcut at the dose of 0.01 milligram per kg. The maximum dose can be zero point 0.5 milligram, right? Or you can also give IV tarbutaline, okay. So still the child is not responding, you may add IV Maxsulf, that is magnesium sulfate, given at the dose of 50 milligram per kg per day IV. Okay. Still, again the child is not responding. So basically, you don't have any other drugs in your hand. So that time you have to go for mechanical ventilator. Okay. Generally, we do not prefer ventilator in case of asthma, but if the child is not responding, you can do nothing. Okay. So that time you have to put the child in a mechanical ventilator, and that should be volume cycled one. Okay, the inspiratory time should be low, the expiratory time should be high. So, and the PEEP, okay, should be minimal. So these are the things you should follow when doing the ventilator settings in case of AE asthma. And what is status asthmatical, students? This is also important. So if the acute exacerbation is not responding to standard treatment, okay, then that is called status asthmaticus, right? So let's look at the flow chart now. So the first one is you have to give oxygen, then you have to give SABA, that is salbutamol or levosalbutamol, whichever is available, along with oxygen. Not responding, go for prednisolone, that is steroid. Not responding, go for ipratropium. Not responding, you go for IV or subcut epinephrine. Not responding, go for IV Maxel, then ventilator. Right? So this is the flowchart you should remember, and also if asked in exam, you should write this. Okay, and After doing the entire treatment, suppose the child has responded to your treatment well, then you need to plan for discharge also. So when you are going to discharge the child, if the child is physically, that is hemodynamically stable, the child is now receiving bronchodilators 3 hours apart. Okay, so the frequent dosing is gone. The bronchodilators, the child is now taking 3 hours apart. This is a criteria you can discharge the child. The SpO2 is maintaining above 92% without oxygen. Okay, so if the child is physically stable, now you can plan for discharge. And one more thing you need to write in the exam also, that is the home written action plan. This is something which can reduce the asthma deaths by 70%. This is very important, students. So this is something which you need to definitely mention in your exam, that you should discharge the child with a written action plan at home, okay, which the parents should follow, okay. And also there is one more criteria, the PEF is more than 70%, okay, then you can go for a plan for a discharge, okay. So that's all about management of acute exacerbation of asthma in children. So if you are not knowing the what are the pulmonary function, what are the lung function abnormalities in asthma, so I've already uploaded a separate video on that. The link is given in the description box. You should definitely go through that as well. So hope this video was useful, students. Thank you for watching the video.